when assessing a patient is put on all our PPE. We want our gloves as well as our glasses. Next thing we want to do is determine, is the scene safe? In this case, we come up to a scene of a car accident and a patient clutching his chest. Next, we want to determine the number of patients we have. Since this is a car accident, there's at least 2 patients. Our primary patient is going to be the patient that's in the most critical condition, and then you send your partner to go after the secondary patient, who's a patient in less critical condition. Next, I want to determine if I need additional resources, which I do because I have 2 patients. So I'm going to call for additional resources, and I'm also going to consider C-spine immobilization with this patient because they were in a car accident.
First thing we're going to do with our primary assessment after we completed our scene size up is we're going to make a general impression of our patient. We're going to look top to bottom real quick, and we're going to form our opinion of how they're looking and go from there. Next, we're going to check our patient's level of consciousness. We're going to check using the AVPU scale. A for whether they're alert and scanning the room. V for verbal, whether they respond to verbal stimuli. P for painful stimuli, whether we can get their attention through painful stimuli. Or U for unresponsive. After we get that, we can also use the GCS scale, the Glasgow Coma scale, to determine their level of consciousness even further. And then from there, we move on to our chief complaint, where if they're able to, we interview our patient to see what the problem is in their words. We want to know how they're feeling and what caused things to escalate to where they are and why they called 911. In this case, our patient was driving their car when they had some severe chest pain and caused them to have a car accident because they were distracted. After we get through the first portion of the primary assessment, we're going to move on to our ABCs. First being the airway. We want to check to make sure that our patient has a patent airway, that they're able to breathe normally, and that their airway is not obstructed by their tongue or any other foreign objects. And if it is, we want to make sure that we secure our airway. For this patient, his airway is patent, so we're not going to insert any oral airway adjuncts. And next, we want to assess their breathing. We want to monitor their chest rise and fall, making sure that they have an adequate rate of breaths and that they have a nice unlabored depth of breathing. After breathing, we want to go ahead and check and see if we need to get any oxygen for our patient in case they aren't getting adequate oxygenation or they aren't breathing at an adequate rate or level. And after that, we want to move on to circulation. We want to check the patient's skin condition to make sure it's warm, pink, and dry. We want to make sure that there's no bleeding anywhere that's a life-threatening concern. And then if there is, we want to go ahead and take care of those right away and leave the minors for the secondary assessment. After that, we want to go ahead and check the patient's pulses, making sure that they have a strong pulse, that their heart rate is going adequately, and they're getting circulation. Once we've completed our primary assessment individual items, we're going to go ahead and make our transport decision. Whether we want to take care of the patient on scene, whether we want to package them up rapidly and get going as soon as possible.
Now we're going to be doing a history taking. With history taking, we're going to be using a sample. And sample stands for signs and symptoms, is what the S stands for. A stands for allergies, M for medications, P for past medical history, L for last oral intake, and E for events leading up to. So we're going to start with S and ask the patient where it hurts exactly. The patient's able to point directly to the center of their chest and state that they have chest pain. And we also observe that the patient is a little flush. That's our sign. Next is allergies. We're going to ask the patient if they have any allergies to medications or any food, and they'll be able to provide that information. Then we'll ask the patient if they take any medications. And next we'll move on to, does the patient have any past medical history? This should line up with your medications. If it doesn't, there's a discrepancy and you need to figure out why, do some investigating. Then we have L, which is last oral intake, and ask the patient when's the last time they ate or took any of their medications. Did they take their medications with food or on time like they were supposed to? Then we have the events leading up to what caused the chest pain. Did the patient do any exercise? Was the patient outside, walking the dog, cutting the lawn? Were they sitting on the couch, watching TV? These are all things that we need to know. And this can help us in taking our history taking. Also, make sure you have a partner who can take notes for you as you do your assessment.
Okay, now we're going to be going over the OPQRST acronym portion of the assessment. OPQRST stands for onset, provocation, quality, radiation, severity, and time. For onset, we're going to be interviewing the patient and asking them how the pain came about. Since they're complaining about chest pain, was it a rapid, oh my god, there's a sharp pain in my chest, or was it a slow, like, oh, I was just doing something, and then progressively the pain just slowly came on and it kept getting worse and worse and worse? So we want to know this information. Next is provocation. Does anything make the pain feel worse or feel better? Does sitting down, laying down, standing up, moving around, what can they do to make it feel better, and what's been going on that makes it feel worse? We want to know this information. Quality is the type of pain that they're feeling. So are they feeling like a deep, sharp, stabbing pain in their chest, or are they feeling like a long, numb, dull pain, or are they feeling something tingly? We want to know this information so that we can build a better picture of what's going on. Next is radiation. We want to know if the pain is just central right here, or if it's spreading out, going to any other places of the body. This is good information for us to know as well. Next is severity. We want to ask the patient if they're able to answer us on a scale of 1 to 10, what kind of pain are you feeling? Is like 0 to 1, not at all, or do we want to ask, or are they going to tell us it's 10, where it's like the worst pain that they've ever felt in their life? If they're not able to answer that way, then we do have the Wong-Baker faces so that they can select an option to see where they fall on that scale. Then last is time. We want to know how long has the pain been going on. Did it start yesterday, this morning, 20 minutes ago when they called 911? This gives us a better picture of how long that it's been going on and what kind of time frame we're looking at.
Now we'll be taking vital signs. I'll be taking the blood pressure.
Another vital sign that we'll be taking is the patient's pulse ox. Take the pulse ox meter. We go ahead and put it on their finger, making sure that they don't have any nail polish or anything on their fingertips that would obstruct the laser's image. And then we make sure to check their pulse ox. If you get a bad reading or something, make sure to try and check other fingers so that you can get a reading, because some people have difficulty with perfusion in their fingertips.
Now I'll be taking a manual heart rate by placing these 2 fingers along the radial side of the arm and feeling for a pulse.
Next, I'm going to go ahead and check the patient's respirations. You want to make sure that the patient doesn't know that you're checking the respiration rate, because then they'll modify it or change it because they become conscious of it. So I'm going to go ahead and pretend to be taking their heart rate from the wrist, and while I'm doing that, I'm going to be watching my time on them, and at about 30 seconds while watching it, I'll go ahead and double the respiratory rate.
Next, I will be listening to breath sounds to determine the quality of his respirations.
Going to be listening in 6 locations, making sure to listen to both the left and right side to compare sounds.
Alright, next we're going to be checking a blood glucose on this patient. If we had a glucometer, we would have the glucometer, the lancet, the test strips, a piece of gauze, as well as a bandage and an alcohol prep. What you would do is first locate which finger you're going to use. It's preferable to go on the side of the finger instead of the tip of the finger because it bleeds more. You would wipe the side of the finger with the alcohol prep. You would use your piece of gauze to dry that off. Use your lancet to puncture the skin. Draw some blood out. Wipe that piece of blood away with your gauze. Draw the next blood out and put that on your test strip, and then wait for your glucometer reading. Now we would be doing our head-to-toe assessment, our full comprehensive head-to-toe assessment. In that, you would check the head by palpating the sides of the head as well as the rear of the head and the top of the head to feel for anything out of place. You're feeling for any crepitus or any motion that shouldn't be there. Then you would check the eyes using your pen light that you have. What you're looking for is equal and reactive pupils as well as the same size. Are they reactive to light? Are they the same size in light as well? Are they dilated? Are they pinpoint? That's what you're looking for. Next, you're going to assess the face. Make sure the face is symmetrical on both sides, especially the mouth. Then you're going to go down to the neck. You're going to check for a midline trachea as well as jugular vein distension in the neck, as well as any crepitus that might be felt directly under the skin.
Alright, next we're going to be checking the chest. We're going to be watching the chest for adequate rise and fall from breaths, making sure that it's bilateral and even. We're going to want to check for any decap BTLS, any deformities, any lacerations, bruises, anything like that. And then we're also going to want to check for structural integrity. All right.
Next, we'll be palpating the stomach to feel for any rebound tenderness or sensitivity. How to palpate a stomach is what you're going to do. You're going to hold your hands like this in a rocking motion. You're going to palpate each quadrant, starting with the furthest one.
Next, we're going to be checking the pelvis, making sure that there's structural integrity, that everything stays where it's supposed to, and there's no crepitus.
Next, you'll have your partner safely log roll the patient so you can inspect the back. What you're looking for on the back is any decap BTLS as well as step-offs in the spine. You're going to want to start at the top of the spine and C1 at the back of the neck and work your way all the way down to the coccyx, the final end of the spine.
Next, we're going to be checking the upper extremities. We're going to be palpating, working our way down, checking for any crepitus, any decap BTLS, and then on the extremities, we're going to be checking for PMS.
Next, on the patient, you want to feel their legs. You want to feel for any decap BTLS, starting at the top of the thigh, working your way all the way down. Make sure you're feeling the front and back of the leg as well. And you want to feel for any pulse as well as the bottom of the foot. And they do have a pulse, and make sure they can feel you touching their toes. And you want to do that on each leg. Now we're going to talk about reassessment. With reassessment, you want a repeat set of vital signs. You want to go over your primary survey once more. You also want to go over your secondary survey once more to see if anything has changed. You would like to go over the patient's chief complaints in more detail. And you would also like to go over any interventions that you did and how it's affecting the patient, whether it's good or bad for the patient. And that's it.
And a 1, 2, 3.
Fantastic veins. He has been enjoying that here on the butt.
Go.
Next.
What
You did that, yeah.
You
You're
just ruined
interrupting.
the take.
sorry.
Get out.
Little red light.
Because